Welcome to Q&A with Prof. A. This is the Ibato kay Doc Bato educational series for medical students and residents. Our question is, Prof. A, how do we approach children with hypertension? We usually ask 4 questions when we approach children with hypertension. The first question is, does the child really have high blood pressure? Number 2, do I have time to ask for any more questions? Number 3, why does the child have high blood pressure? And number 4, what should we do about it? The first question is, does the child really have hypertension? Very important is to confirm all blood pressure readings before acting, because we all know that the equipment is inherently flawed. It's hard to find, or it gives inaccurate readings if not used right. Sometimes spurious elevations are common, especially in very young children who are afraid of the doctor or who keep on crying. Sometimes mild hypertension takes weeks to confirm. This is the most recent 2017 American Academy of Pediatrics hypertension guidelines. As you can see, it is classified now as normotensive, elevated BP, stage 1 hypertension, and stage 2 hypertension. And from this, we know that blood pressure is affected by the child's age, sex, and height. Number 2 question, do I have time to ask for any more questions? Is this an emergency? There are 2 types. You have your hypertensive emergency, which is your stage 2 hypertension with symptoms of end organ damage. And what is important is to treat the patient and not the numbers. This is the first general recommendation. To decrease the mean arterial pressure to no more than 10 to 25% within the first hour. Then a goal of 160/90 within the first 8 hours and normalization over 8 to 24 hours. What about hypertensive urgency? This is stage 2 hypertension that makes you just uncomfortable. There are no end organ damage. And in terms of managing this, it is not necessary to lower blood pressure acutely, which can result to brain hypoperfusion. We control the blood pressure over 24 to 48 hours. Unlike emergencies where IV drugs are preferred, for urgencies, PO medication is recommended. Number 3 question, why does the child have hypertension? Always remember, the younger the patient with hypertension, the more likely you'll find a cause. And the higher the blood pressure, the more likely there is a cause. This means that if you see a very young child with very, very high blood pressure, think secondary. The prevalence of hypertension is around 1 to 3%. And among this 1 to 3%, 90% is primary, or what we call as essential, and 10% is secondary. Among the secondary causes of hypertension, 90% of them is due to a renal etiology, while 10% may be due to a cardiac, endocrine, or even drug-induced. And if a patient would come in a hypertensive emergency or urgency, 90% of the time, it is due to a renal parenchymal disease and 10% is due to a renovascular cause. This means always consider a kidney problem in a hypertensive child, such that your initial critical laboratory is a urinalysis. The most common cause of renal hypertension is your acute glomerulonephritis, which presents with edema and hematuria, then followed by your renovascular hypertension, and they present with discrepancy in pulses and blood pressure of the upper and lower extremity. And your third most common cause of renal hypertension is your reflux nephropathy, which presents with recurrent urinary tract infection and chronic kidney disease. This table summarizes the commonest cause of hypertension in the different age groups. As you can see, in the newborn period, it is your renovascular hypertension. While from infancy up to 10 years, it is your glomerulonephritis. While in adolescence, it is your primary hypertension. What is this primary hypertension or essential hypertension? We all know that the heritability of primary hypertension is 30% genetic and 70% familial. It usually presents with elevated blood pressure, sometimes normal, sometimes not, or with white coat hypertension. They usually have a family history of hypertension and even obesity. Several genes have already been identified, and it is polygenic in form. And question number 4, what should we do about it? Always remember that mechanism dictates therapy, such that you formulate a hypothesis of the mechanism of hypertension and its contributing factors. Number 2, identify comorbid conditions and consider whether or not these disorders may be negatively affected by these agents. Number 3, monitor for adverse drug events. This table represents the different mechanisms of hypertension and its corresponding conditions or disease entities, from increased heart rate, increased volume, increased vascular resistance, or a combination of the three. This table represents the different pharmacologic agents used in the treatment of pediatric hypertension. As you can see, it follows the concept of mechanism dictates therapy. For example, we all know that thyroid problems increases the heart rate, leading to hypertension. Therefore, the drug of choice will be beta blockers. Similarly, primary hypertension has been elucidated to be due to renin mediation and fluid retention, such that a combination of ACE inhibitors and diuretics will be the drug of choice. For more high-yield concepts in pediatric nephrology, don't forget to click the subscribe button.